All my friends over here in India, and good evening to all those who are in the United States of America. And welcome to this weekly edition of the webinars that are being conducted by Andhra Medical College, Visakhapatnam. Welcome to this 99th episode. And we have been able to conduct this for the past more than 1.5 years with the cooperation of those who are in India as well as in America. I have great friends in America like Dr. Sridhar Chilumuri, Dr. Ram Kairam, Dr. Guntupalli, so on and so forth. So they have taken enormous trouble in getting quality speakers and updating our knowledge day in and day out. You are all aware that in the month of May, we had a regular sessions on every day. So it reached 199 today. And next week, we're going to have the 100th episode, which will be addressed by Dr. Sridhar Chilumuri, who has presented many times on this forum. So the beauty of this program is not only in its continuity or in its regularity, but also the interaction it has towards the end of the presentation by the speaker. The real lifetime scenarios are discussed and a lot of solutions are given to the problems that are being faced day in and day out. So the last 1.5 years have given us enormous experience, starting from the days when we did not have proper protocols. We were not aware as to what needs to be done. People like Dr. Mukherjee, the experts, have given us the right direction, and the experience of Dr. Sridhar Chilumuri has given us the direction. So with that, we could reasonably come to certain conclusions and reach out to the protocols, keeping in view of the ICMR protocols that we had from time to time. And at the same time, we have missed something, and the death toll was too much in the second wave, and there are some variants coming up. So the knowledge is getting updated every day. So we felt that it is appropriate to have a recap on what's happening in the last happened in the last 1.5 years. So I thought for this episode, Dr. M.S. Mukherjee would be the right person, who has got an enormous knowledge on COVID-19, apart from his own cardiology. As you're all aware, he is a very popular person, not only in India, but around the world. And this particular disease, the COVID-19, has taught us that there is no real specialist in this. Everybody can be a specialist in this, and at the same time, whoever has the better knowledge would always be adored, who will be followed. So Dr. M.S. Mukherjee, who graduated from Guntur Medical College and later did his MD and DM from Gandhi Medical College in Hyderabad, is a senior interventional cardiologist in Medicover hospitals and in Pulse hospitals. And he is an ardent learner, as well as he shares his knowledge very widely. You must have seen him in the national TV also many times, who talks about the evidence-based medicine and not merely anecdotal. So that is what brings in a lot of good aspects out of the COVID-19. So for giving us a recap as to what we should learn from the last almost 2 years, it's appropriate to have the things that we have missed, in fact. Like, there are many issues which we could have done it better, but still we did not do it all that well. So if you know the past, you can be a better person in future. Those who cannot remember the past are condemned to repeat it. So it's always apt to learn from our own mistakes for us, so that we can always do better in the coming days. So with that in idea, I have posed certain questions to Dr. M.S. Mukherjee, and he was so kind to come in and share his expertise. Dr. Mukherjee has been there on this forum many times before, but still we always feel that when we need something, when we encounter something new, when we have some problem, he is always there to guide us. So with these introductory remarks, I wish Dr. Mukherjee would cover all those which we have learned in the past 1.5 years, and where we went wrong and how we can better ourselves. Now, over to you, Dr. Mukherjee. And at the end of your session, we will have the interaction by the audience.
Thank you very much, Dr. Sudhakar garu. You have been the vaccine against misinformation in COVID-19 times. I should really congratulate you for the 99th episode. I hope that you will definitely continue it beyond 100, because this session has been enormously helpful for physicians as well as patients all over the world. And then it is so commendable a job that you have done. This requires a lot of integrity and a lot of ability to organize. Thank you very much for this. Today, before I start this topic, I would like to give a few disclaimers. Now, I have deliberately changed the title of the program in the lessons learned from, I have made it lessons not learned in COVID pandemic. I'd like to discuss some contentious issues here as well. But as far as possible, I'd try to be as apolitical as possible. But here, we need to touch upon certain things which are sensitive. And then while I say that the list that I'm going to put in front of you is neither extensive or exhaustive, nor a comprehensive one, but this is my view of the pandemic, what could have been made better. And then there are a lot of good things that have happened in pandemic that we should understand. The most important one is not paywalling information. That is something that really helped in the for the scientists in the developing countries to keep them abreast of the latest developments that are happening all over the world, and also to treat their patients better. That is a great thing that all the journals have come together and then have done it. Now, if I want a full text article from Lancet, NEJM, or JAMA, any day I can get it without paying anything. That is a great thing that has been done in COVID, and that should be the way forward in science as together. Science should not earn by selling itself. Science should earn by the exploits and the actually implementations of that science, not from selling the science itself. That's what is my concern. And then this is the good thing that has happened. A lot of other good things have happened. We have the first time we have seen all the politicians coming together and then trying to work out better ways of managing this pandemic. Some have succeeded, some may not have succeeded, but everyone have tried it in sincerity. This is the lesson number one that we should have learned, but we knew that it was there, but we did not learn it properly. We knew that vaccine equity was essential to prevent emergence of new variants. This is what we understood from the beginning. Now, how do the new variants emerge? New variants emerge whenever the viruses multiply unabated in certain populations. And once the virus replicates a lot, it gives rise to new mutations. And these mutations together form variants. And we know now, we are fearing that Omicron may surpass Delta and then replace all the other variants. But it is important to know that Omicron has 53 mutations known so far, and then 32 of them in the spike protein, 10 of them in the receptor binding protein, and 3 of them in furin cleavage site. Now, we knew that this is going to happen. We knew that new variants are going to come up, but we couldn't achieve vaccine equity. Why did we not achieve it, sir? We did not achieve it because some countries decided to hoard the vaccines and keep for themselves, while other countries who are developing nations, they did not have enough vaccines to vaccinate. It is not vaccine hesitancy that has produced the new variant, but it is the vaccine inavailability in certain countries that has produced the new variant. That we have to understand and accept. Why is it so difficult to give them the vaccines? Maybe the production is not enough. That's why they could not give the vaccines. But they could have given the technology. They could have given the technology. And then worldwide, there is a call for making the vaccine technology totally free for all the countries. And then this should be the number one step in doing this. I'm not talking about any moral reason to do this. I'm pleading for the pragmatic nature of the people with the technology, because if everyone is safe, then only you are safe. Ladies and gentlemen, if Omicron starts in Botswana, it is going to reach the United States, it's going to hit India. And then a new variant may come up, which is much more powerful than Omicron, unless we vaccinate everyone in the world. And then, having said this, we have seen that Omicron bypasses the immunity given by vaccines. So what should have been done? Not only that vaccine equity has to be achieved, but newer vaccines should have been made faster. Now, we had a Delta variant sweeping across. We knew that reduced effectiveness of the vaccines is there. And what is our response to it? Did we make a customary vaccine towards Delta? We could not do it. What we did is we gave the same dose of vaccine again. We tried to give the booster and then protect ourselves from Delta. Because of that, now we'll not be able to prepare for Omicron that much faster. Now Moderna and Pfizer are saying that we'll come up with a new vaccine for the Omicron variant in the next 2 to 3 months. But if they had come with a new dose for Delta itself, now making a new dose for Omicron would have been much easier. That's where vaccination is essential. Updating vaccination is even more essential. Achieving vaccine equity is the fundamental call. Unless we do that, we'll not get out of this pandemic anytime soon. That is the lesson number one that is not learned, that should be learned. The next lesson that I am talking about is that so far we are unable to design a proper correlate of protection. Now, what do? Now we give 2 doses of vaccine. We say in India that you are between 70 to 80% protected. With mRNA vaccine, perhaps more, but the available vaccines in India, 70 to 75 or 70 to 80%, you are protected. So that means that leaves some 25% of the people unprotected. So what the vaccine companies are trying to tell you is, because some people are not protected, because sometimes the vaccine efficacy is waning, you give a dose to 100% of these individuals 6 months down the line. Is it a practical approach? The simple common sense approach would be to design a proper level of correlate and then give the people, 25% of the people who are not properly protected, the extra dose. That's where you can preserve the doses of vaccine. You can really give the vaccine to those people who require it. Now, what do I mean by proper correlate of protection? Now you are doing antibody levels. Now, US FDA explicitly states that you cannot use an antibody level to see your level of protection following a vaccination. That is an explicit statement given by US FDA. But I'm asking, ladies and gentlemen, if you design an intervention to treat any disease, would you not have a correlate to test its efficacy? If you don't have the test of efficacy, how can you be sure that your intervention is working at all? And is it such a far-fetched approach? All we need is a proper standardized antibody test, and then determine a threshold of how many arbitrary units the antibody should be there in a particular person so that he'll not be infected again. And then this research has not been given importance because the vaccine companies have absolutely no interest to find out this, because they want to revaccinate these 100% of the population. They don't want to vaccinate the 25% of the people who are not protected. They don't want to vaccinate people who have no antibodies or no protective antibodies. They want to vaccinate everyone. And it's not out of their shrewdness. It is not out of their own benefit that they are doing this. They have no amount of incentive to do this. The government should step in, find out a proper correlate of protection, then only we can move forward. Otherwise, we'll keep on repeating this cycle. Now, people who are infected prior, they do not all have the same level of protection. That we know, because they don't develop the same level of antibodies. And what we are thinking now, people who are infected and followed by vaccination, this is called the hybrid vaccination, hybrid immunity. People who have hybrid immunity are better protected against Omicron. Now, I want one test to tell me who are protected against this variant or against this virus. Is that a great test to be asked for? No. That is what the research has to be focused, and it is not been focused. There are several studies which are being doing, but that has not been a mandatory thing. That is not foremost in the eyes of the scientists as of now. The third thing, this is something that is so common sense that you will all think that why did we miss this? Now, how do new variants develop? We have discussed it in slide 1. We said that it is an unmitigated replication of the virus producing more mutations that will give to variants. Now, how did Delta come up? Delta come up because the virus replicated in an immunocompromised host for a long time, and then it spread to others. That's where the Delta has come out. How did the Omicron come? Omicron has multiplied perhaps in a HIV positive, unvaccinated, untreated individual for a long time, because Omicron doesn't come from Delta. Omicron comes all the way from Alpha. And then it took almost a year in its evolution, and then it comes up with a new variant. Now, we all know that people who are immunocompromised, people who are on long-term steroids, people who are on cancer chemotherapy, people who have malignancy, these people, they cannot eliminate the virus as the rest of us can. Now, we have a standard 14-day protocol for isolation. Now, we should have designed special isolation protocols until the RT-PCR comes negative in populations with less immunity. That would save not only them, their neighbors, their family members, and the whole world. The new variants could have been prevented if we have realized that isolation protocols for the immunocompromised must be different from the isolation protocols for the general public. That should have been the approach. That was not the approach. The lesson number 4. Now, in India, a lot of people are advising not to panic from Omicron. That is the correct thing to do. That is the correct thing to do. We should not panic from Omicron. But the reason they are using to tell people not to panic is this. They say that Omicron is going to be very mild infection in India because we have more than 70% of people with antibodies, and we have a lot more infections that have happened since the ICMR analysis. So we'll be better protected. That's why the Omicron variant the wave is going to be a smaller one rather than the Delta variant. That is the implication given. Now, ICMR does the zero surveys. They said this was in July, August. They gave an estimate of around 70% of the people having antibodies. But how many people they have studied? 30,000, 40,000? What was the method they have adopted? A rapid antibody test. What is the threshold of the antibodies that they detected? No one knows. And how did they correlate the same antibody levels with the protection? Now, the implication that has gone into people is that when ICMR says that the 70% of the people have antibodies, people think that these 70% are protected from subsequent disease, which is not true by any level of any stretch of imagination. But even now, all the doctors in India, almost all the doctors in India feel that these 70 to 75% are totally protected from the further disease. That is the wrong thing. Why that is wrong? Because this antibody level was not standardized. ICMR itself says, don't get the antibody tests and think that you are protected. And then they don't have a proper sample across. It's not a huge sample. It is 30 to 40,000 people. And you are not trying to extrapolate the same thing to a vast country, which is not possible. So what I dare say is that this 70% of people are not totally protected. Now, why this is important to specify? Because people are thinking, let Omicron march over the next rest 25%, and then we'll reach a herd immunity. We have been there. We have warned against this Great Barrington Declaration, saying that the herd immunity in COVID-19 is very, very difficult to achieve through natural infections, because the immunity that comes from natural infection wanes. It is not uniform. And then right now with Omicron variant, There is a study, not peer-reviewed, of course. There is a study which tells that this infects people who have been infected 2.39 times more than the rest of the variants. That is almost 200 or 250% more infectivity for the reinfections, not the breakthrough infections. Even breakthrough infections are higher with Omicron. So the antibody levels of the community, the percentage of the people having an antibody, is not the same as the percentage of the people in the society who are protected. This is a fundamental concept that we need to understand and move forward. Otherwise, people will keep on calling for lesser precautions against Omicron, asking for the Omicron to sweep through the rest of the population so that we can have a herd immunity. That approach is going to be disastrous. That is what is the lesson that the Delta has taught us. Even when the population was 50% had antibodies, even then Delta swept through and then caused a lot of deaths and morbidity. Now, if we apply the same logic to Omicron, again, we are going to suffer. We need to tell people not to panic, but not because of this reason. The second thing, the lesson number 5. Now, CDC has given this statement long ago. The transmission through fomites is less than 1 in 10,000. Less than 1 in 10,000. This is such a long ago CDC has told. This is after people have understood that COVID-19 is not only spread through by droplets, it spreads through the air. It spreads through the air. That we knew, we accepted it. It took guts for the scientists to come up and say this, but they said. So now once we know that it doesn't spread through droplets, it spreads through air. And then it doesn't spread through fomites. We are still harping on sanitizers in every public health speech. Why are we doing that? And what is the harm in doing that? Let us say it is an extra precaution that you are taking. But when you equate mask with a sanitizer, do you see the difference? The mask is much greater in giving you the protection rather than a sanitizer. And both are kept equally, while ventilation is not talked about. Your SMS principle doesn't carry ventilation. That's why people are meeting in closed spaces. That's why people are not understanding the concept of ventilation is much more better in preventing spread rather than using a hand sanitizer. Now, this is where we have to practice evidence-based medicine. I have problem against people talking about PPEs while not wearing a proper N95 mask in COVID ICUs. If the fomite spread is so rare, why do we wear PPEs? Why can't we wear just N95 masks? This is something the developing nations have to think about. We were concentrating on the PPEs. There have to be a study with PPE and without PPE where a proper N95 mask is worn. And then the percentage of infected should be known. Then we can make a proper recommendation about this. But as far as now, the sanitizer, placing the same emphasis on mask and sanitizer is going to cause problems. We have to distinguish between these two, saying that wearing the mask properly, always and correctly is going to prevent an infection, be it Delta, be it Omicron, not using the sanitizer the whole day. And a lot of people come with sanitizer sprays. They spray it in the waiting chair or the reception area also. I hope they do not spray it on my face, but they do that because this is what people think. Sanitizing will prevent COVID. It doesn't. We have to make sure that they understand that mask is much more important than using sanitizer. I'm not against use of sanitizers, but it cannot be placed on the same pedestal as the mask. That is where my observation comes. And now we are talking about the private hospitals which have charged more money. We are talking about the vaccination drive, which is going to cost millions of dollars. We are talking about COVID mitigation strategies, which are costing enormously. But why are we not talking about the nutraceutical industries, which made $3 billion? This is not all over the world. This is in India, ladies and gentlemen. in 2020. This is the nutraceutical industry business that was done. You're talking about the remdesivir cost. You'll be talking about the Paxlovid cost, and that will hurt you a lot, I'm sure. But this $3.9 billion went down the drain while people swallowed nutraceuticals. Do they boost immunity? Do they boost immunity to any extent? Why did we give B complex tablets to so many gullible people? Why did we not tell that this is not going to prevent it? And then, ladies and gentlemen, for those in India, $4 billion is roughly 30,000 crores of rupees. 30,000 crores of rupees. We spent all this money and we did not want people not to take this. We did not tell them that you are spending your money here where it is not going to give you any results. That's where we have to learn that lesson and make sure that we don't spend another $7 billion in 2021 for nutraceutical industry. This is where I feel strongly about this. Now, ICMR has approved these medications for COVID-19. Itolizumab, favipiravir, 2DG, and also pegylated interferon alpha. I did not write that. So these 4 medicines have been approved by ICMR, yet they do not appear in ICMR treatment guidelines. They do not appear in DCGI treatment guidelines. Both have given protocols slightly different from each other, but all the 4 of these medications, they do not appear anywhere in these guidelines. Now, if you have approved a medicine for COVID-19, and if it is not there in your own guideline, there is some problem with that. Either the medicine is not working, or you don't think that is essential for the treatment plan. So it has to be made clear. And then if the medicine is not useful, please revoke its license for COVID-19. This is, let us say 2DG, we are not giving for any other usage. Itolizumab, we perhaps give in other reasons for in dermatology. Favipiravir, we don't use it for any other reason. So either you include these things in your guidelines, or ladies and gentlemen, I request them to reformulate the guidelines carefully. Now, treatment guidelines have not been finalized in India properly. Now, COVID-19 treatment is not a joke. There are several scenarios involved, and we need to understand each scenario separately and then recommend it. So, a guideline from the apex organization like ICMR or DCGI, I would expect it at least 200 pages thick. A guideline tackling each and every scenario, specifying what to do in a particular case. Now, Dr. Sudhakar was mentioning the other day, we are discussing about each and individual case and then suggesting appropriate ways and means. If there is a guideline before the Omicron hits India, we'll have a proper basis of treatment. Otherwise, what happens is the proven treatments and the unproven treatments will all merge together, and then the treatment will become so chaotic and expensive that India cannot afford it. So it is important for us to discuss, debate, and then bring out guidelines, ratify these treatment protocols properly, and then move forward to tackling a new epidemic, new pandemic, new wave of pandemic. Now, can we do this? Is it possible? It is possible. 100% of the time. I can tell you that this can be done, but it has to be done properly and by an authoritative figure. And that's what I'm requesting. And then this is the lesson we are learning bitterly. We almost lost the fight with misinformation. There was so much of misinformation in COVID-19 that you cannot fight it. Now, yesterday, there is a meme coming up in social media saying that there is a movie called The Omicron Variant in 1963 itself. I mean, is this something that has been, we have been forewarned about? Will there be an Omicron variant in 1963 they have predicted? Unfortunately, that also is a false notion. There was no movie named Omicron variant in 1963. I'm just telling you a simple example that has come up yesterday. But the misinformation is so much out there. Every day you turn onto the social media or television channels, there is so much of misinformation. And then we have to have a proper body from the government to fight the misinformation. Now, why am I saying this is, why am I asking for a better guideline is, now, the government guideline says that you cannot give the COVID-19 vaccine within 14 days of giving any other vaccination, or after giving COVID vaccination, you cannot give any other vaccination within 14 days. That was the initial recommendation, simple recommendation, easy to follow. But is it qualified enough? Now, with all the studies that have come up, CDC has revised its recommendation saying that this 14-day rule doesn't apply. If you want to take the vaccine, you can take the vaccine, no issue. For example, in an emergency situation, a COVID-19 patient comes, a patient who has taken a COVID-19 vaccine is bitten by a dog the next day. Would he take the rabies vaccine or not? Was it specified in the vaccination protocol? That is where people have a problem. Now, a person takes a COVID vaccine. Next day, he suffers from a fracture. Can he take a aceclofenac paracetamol tablet? People are not sure of this. The misinformation says that people die with painkillers taken after COVID vaccination, which has absolutely no proof of evidence. Yet, falsehoods fly while the people with knowledge keep quiet. We all tell individual people, but if it comes from the government, if it comes from a trusted source, then people will be more ready to accept it. And they should go proactively, take out all the misinformation, talk about it, and dispel the myths. That's what the government is supposed to do. And then when the Omicron variant is coming, there is a lot of effort from the government. I'm not trying to blame the government. This is something that can be easily done. That's what I'm asking about. And the lesson number 9 that we have not learned is that investigational drugs should only be used for clinical investigation. Now, practitioner from Bhimavaram calls me and tells that he has given stem cell treatment for COVID-19 for 10 people. They brought it from Delhi, and then out of them, 2 to 3 people survived. Can we give such an expensive treatment? How do we know that whether something works or not? What do we do in the face of losing a patient? These are the important questions. Now, experimental medications can all be used, but only under a proper, valid framework of investigation. When it is cleared by ethical committee only, then we should use the experimental medicines. Be it herbal medicine, be it homeopathic medicine, be it an Ayurvedic medicine, most importantly, if it is an allopathic medicine, because we have a system in place to have these. Immunoglobulins have been given. All kinds of immunosuppressants have been given. Enormous doses of steroids have been given. Now, I have seen a doctor receiving 32 milligrams of methylprednisolone 3 times a day and 12 milligrams of dexamethasone twice daily, all for a 29-year-old doctor. He is taking that. This is not under any treatment protocol, investigational protocol. Just like that, they're taking. Just like that, doctors are prescribing things that may have been proven elsewhere, that may have been suggested to have benefit elsewhere. Someone calls and tells you, try fluoxamine, it works better. Immediately you try fluoxamine without a frame of clinical study, without any government guideline. This is where the regulatory bodies have to give direction to all the practicing doctors. If you are using an investigational medicine, inform the proper authority. There is a CTRI. You take a proper approval from an ethical committee, and ethical committees have to be formed, and ethical committee approval has to be taken. Then only these drugs can be used. Otherwise, we'll be subjecting the patients to enormous amount of investigations, enormously expensive medications, which have absolutely no value. This is very important. Not only that, if we are gaining some important information, we'll lose all that. If we don't do this in a framework, like in my center, we gave immunoglobulin, IV immunoglobulin for 4 patients. 4 patients who are very, very sick, almost about to die. 2 of them survived. If I don't publish that paper, all the information is gone down the drain. All the things. But if we do this under a proper investigational protocol, that will be useful for doctors and the patients all over the world. And we have to learn this lesson, and we have to be careful about it. This, ladies and gentlemen, is by far the most important thing that I'm going to tell you. This is going to save lives. The things that we don't know, we should accept that we don't know. Because after the first wave, people in India, we thought that we are immune to any second waves. And then a lot of people explained why it is so, why we are safe, why India is different from the rest of the world, why we are more protected. We have less hygiene, that's why we are more protected. We have better genes, that's why we are more protected. We have an younger population, that's why we are more protected. The common things in all these arguments is the assumption that we are protected. We did not know at the time that we are not protected, that we are not better off than any other nation in the world. We are simply another part of the world which may be affected as much as the next nation. We did not accept this. We have to accept this. Then only we'll move forward. Right now, I dare say that we don't exactly know why children are spared in a COVID pandemic. We all have theories. I'll tell you some of the theories. We think that the ACE receptors are much less in children. We think that the innate immunity doesn't distinguish between the viruses so much as the acquired immunity. Innate immunity can act against the COVID-19, SARS-CoV-2 better. And there are a lot of other things also, like children will have other respiratory virus infections, which may have some cross immunity with the SARS-CoV-2. These are some of the hypotheses put forward. But if we accept that we don't know why children have not been affected so far, then we'll be able to explain once if they get affected. Now in South Africa, there are disturbing reports that are coming up from the Gauteng province, saying that 10% of the people who are admitted in hospitals with COVID-19 are below the age of 5. Below the age of 5. Ladies and gentlemen, 10% of the people who are admitted, not infected, mind you. This is a very disturbing statistic that has come up from the Gauteng province yesterday. Now, if we don't accept that we don't know why children were unaffected in the first 2 waves or 3 waves or whatever, if we accept, then only we'll be able to move forward and try to find out why these people are going to be affected later, and why there is a chance that kids can be affected. We have to keep an open mind about it. But a lot of times we are feigning knowledge, we are feigning wisdom where we don't have something. That is where we are going to be struck badly. Even for the Omicron variant also, it is important for us to understand that we don't have all the answers. We don't have all the answers. We have only a few answers. And the answers are good. But unless we know specifically, it doesn't hurt you to say that we don't know specifically. I faced this challenge while talking in TV channels. The TV channels, they want someone to tell them confidently that they know what they are talking about. When I go there, I try to balance and then say that we don't know something. People don't like it. People like people who know everything. People like to say that a person who says that he knows certainly this for sure, they believe them. But the problem is, if we don't accept that we don't know, sometimes it can have disastrous consequences. So, ladies and gentlemen, the facts that we don't know, the things that we don't know, we have to be humble enough to accept that we don't know. Now, wastewater RT-PCR, this is very important investigation. The CCMB has done a lot of work on this, and it is grossly underutilized. Grossly underutilized. Wastewater SARS-CoV-2, if it is detected, it will predate any wave of pandemic by at least 2 to 3 weeks. Now, if you do the wastewater analysis, and then find SARS-CoV-2, you can warn people in which clusters, in which districts, in which cities the next infections are going to be. This is grossly underutilized. And so is the fact that early RT-PCR tests, you get what is known as the cycle threshold value. In an early wave of a pandemic, the cycle thresholds are much lesser when rather than at the end of a wave. So if you have an average CT value of all the positive samples in Hyderabad, and if you find that average CT value is low, you can brace yourself up for a next wave. And this is a simple thing to do, which we are not able to do. We did not listen. We are trying to predict whether a wave will come or not, depending upon what experts say. But there are ways in wastewater RT-PCR tests and in the CT values in the random samples that they have done. They have to follow science. And this is, I have almost 15 lessons, 2 to 3 more, then I'll stop for a discussion. And this is another thing that we could not warn people about properly. COVID-19 spreads through air, that we know. But what we did not warn them about is, even if you are holed up in your apartment, still you can get COVID-19, even if you are not exposed to outside population. This happens through washrooms. There is scientific evidence which says that in apartments, vertical transmission occurs. This vertical transmission doesn't mean from mother to baby. It means that among the vertically aligned apartments, the SARS-CoV-2 can spread through the bathroom vents. These studies have come. They have been conclusively proven, but yet we couldn't warn them enough, and we couldn't tell people how to protect themselves in such a situation. Most of the elderly people, they don't move out from home once a new wave comes. They'll be stationed at home, but still they're at a risk of contracting COVID-19. We know that. We did not alert people to that. And this is something that I see. Now I go to a mall, I go to a restaurant, I go to any public place. They have this mandatory guy with a temperature gun. And in the last few months, wherever I went, I was asking them only one question. What is the normal temperature? None of them answered. None of them answered. They don't know what is the normal temperature. They shoot with the temperature gun that they have in hand, and then they forget about it. They don't know what to do with it. And I have not seen a single person being stopped outside a mall or a restaurant while they screen for temperature checks. This is simply not happening. So we have to advise people against the futility of temperature checks. A lot of money is being wasted like this. A lot of money is being wasted like this. How many people are being stopped in any mall because they have temperature? No one is being stopped, but these temperature checks go on. And then they give a false sense of security. They should have done a better thing. They should have checked the mask. They should have seen if there is a valve on the mask. They should have warned the people who are wearing a valved mask to use another mask over it. Mask over or change the mask. Valved masks have to go. And that's where it just simply checking for a mask would have been much better rather than using a temperature check in the public places. Lesson 14, we depend in India. We are still depending solely on genetic sequencing for a variant identification. Whereas we could have identified the variant by being the Omicron variant, for example, by being an S gene deficient thing. Now, we have different genes that we test for. In the RT-PCR test report, if you see, what we'll be seeing, RDRP gene, N gene, E gene, and then ORF1b gene. These are some of the genes that I use in RT-PCR tests to detect whether the patient is having a SARS-CoV-2 or not. What all we have to do is add S gene probe to it and bring that RT-PCR test to India so that we can monitor the emergence of variant much more easily. Now, we have some 5 to 10 patients who have tested positive in Mumbai for COVID-19, but we haven't identified which variant that they have. It will take at least 5 to 7 days, they are saying. If you have a proper RT-PCR probe, that can be known in minutes. That's why we should have a proper RT-PCR report. Not every variant will have such a facility, but Delta is an S gene positive variant, and Omicron is an S gene deficient variant. So when you see S gene deficient variant, you can simply predict that they have Omicron variant, and then you can send it for genomic sequencing. But this could have come much easier, and then why we are not equipped for it so far just beats me. And then lastly, we have to tell people why we shouldn't fear Omicron. We shouldn't fear Omicron because we trust in people to take proper precautions. We shouldn't fear Omicron because we trust the authority to come up with proper guidelines regarding treatment and isolation protocols. We trust Omicron because we will still believe that vaccines will have something to do with the severity of infection following Omicron variant. We warn the people to wear their masks, to follow their COVID appropriate behavior, to get double vaccinated, and we plead the authority, we plead the government to take an early stance on the boosters, on the pediatric vaccinations, and to ratify the protocols, and to improve communication facilities in the government hospitals, and to do an insurance in the private-public partnership in private hospitals, and then stick to that insurance so that people will not suffer financially. And because we are sure that the people and the governments and media are going to do all these things, we shouldn't be afraid of Omicron. We shouldn't say that Omicron is a milder variant, that's why don't be afraid. That is going to cause a lot of problems. That is the stand taken by a lot of people today. Omicron variant is causing only mild infections. That is not what you are supposed to say. You are supposed to say that we can beat the Omicron variant if you take proper precautions and seek early management. Ladies and gentlemen, thank you very much for a patient hearing. That's all I have to say today.
Thank you very much, Mukherjee, for a wonderful and very forceful presentation. And you have made your point very, very clear. So before we go on to the discussion, let me just clear the chat box for now. And Dr. Vijay Shekhar compliments you for that particular idea of sharing the technology to all the nations so that the vaccine will be available easily. That's a wonderful idea that one should have. Like, as you said, science is not for sale. It should be shared. Somebody is calling. Yeah. That's a compliment from Vijay Shekhar. And later, Dr. Sriram Chandramurthy has a point here which you have not touched upon. Like, he says that we have seen a lot of mucormycosis after the second wave, and which was not seen after the first wave as much. And though the numbers are so high in other countries also, they all have not had similar experience. And though diabetes and the usage of steroids have been named as few of the culprits, it has been shown that there are many people who have not used steroids, many people who are not diabetics, for that matter, some of the people who are not even diagnosed to have the COVID-19 also had this particular problem. And he wanted to know as to where do we stand on that today?
No.
Do we have any answers?
Yeah. Now, a Chandigarh study definitely says that steroid usage has been the most important. The PGI Chandigarh has submitted one study, which was published in a NEJM, I believe. So, or it was published in CDC. I don't remember where, but they have given a specific study which said that mucormycosis is related definitely to increased steroid usage. There is no doubt about it. But like you said, there are sporadic cases without the usage of steroid, without actually being diabetic, without actually having a COVID infection, having mucormycosis. But when I have seen the real world picture, it is mostly people who have recovered from COVID-19. and mostly in patients who have used high doses of steroids. For the rest of the people, like you said, we still don't have much of an answer, but predominantly it is driven by this. That far is known.
Yeah. Thank you, Mukherjee. And if there are any questions from others, so they're free to unmute and ask Dr. Mukherjee. And before that, I would request Dr. Buddharaju. Dr. Kairam is online. Would you like to say something, Dr. Kairam?
I'm very eager to ask one question. We have learned a lot from the beginning of this disease. We dealt with inappropriate treatments when we did not know enough, like chloromycin, ivermectin, intravenous vitamin C, etc., etc., etc. But I'm struck by what the speaker said. About 10 patients from one small town like Bhimavaram had stem cell transplant. Dr. Mukherjee, can you shed some light on that? Was it mostly driven by one local doctor who did not have any respect for science, or the supplier of the stem cell from Delhi, or from some outside consultation from outside the country? How could this have happened? What did you learn? Is it just one doctor who did this?
No, sir. It was rampant across the Andhra Pradesh and Telangana. A lot of people have given stem cell transfusion. It's not replacement, transfusion that they have given. They bring vials from Delhi and then they infuse the stem cells. That I know. I have seen patients who have received that. It's expensive. It's very expensive in the sense that 1.25 lakh per injection, and then they give 3 days injections in 3 days. That's what they have done. But I cannot name a particular physician. I'm sorry about it. But this has happened. It is not with a single sporadic incident. No. All across AP and Telangana, stem cells are one of the things. But a lot of other investigational things therapies have been given by ordinary physicians day in and day out. That's what has happened in the last wave. That's what I'm cautioning against. This has to be done only under a clinical investigation protocol only. This cannot happen randomly. And this is going to have a detrimental effect if we don't check it properly.
Thank you. Thank you. I know this is a difficult nut to crack, but I wished somebody like you or the so-called advisory council in Andhra Pradesh, whatever regulatory bodies that exist, may have to work on this in case we get into this trouble again, because it was egregious the way in which people were treated in the beginning, and I was particularly offended by the stem cell bit. But what can I do? So I'm glad you mentioned that it was multiple doctors involved. I think the culprit here could be the guy who's supplying the stem cells. Should have some conscience. Thank you.
Yeah. Dr. Bhavani Rao, can you go ahead and ask your question before I go to Dr. Buddharaju? Dr. Bhavani Rao, please. Yeah.
Sir, good morning, and good morning to everyone in the meeting. So I congratulate Dr. Mukherjee. This is a wonderful knowledge-packed presentation. I amazed about his energy. He's looking after his nursing home, keeping abreast with the knowledge, and advising the general public also. So I have few comments. So if you see the natural history of Spanish flu, it has 3 waves: the first wave, the second wave, and third wave. The first wave is mild, the second wave is about 4 times than the first wave, and the third wave is about 2 times, and after that it waned away. It waned away not because of vaccines, it waned away because of natural mutations. So the mutations, the latter mutations are such that the infectivity and spread is far more and the pathogenicity is less. Are we in the midst of same natural history in case of COVID-19 also? Is the Omicron variant is less pathogenic and more contagious? So if that is the case, if we confirm that it is very, very mild when compared to other variants, and it is spreading fast, are we not losing an opportunity to spread it, to eradicate the COVID-19 by letting it spread fast? That is one question. And I agree completely with you about fact check in one of the slides. So there is a lot of information that is coming out of social media. So as you said, Omicron movie is false, but another movie is there, Contagion, which is, it predicted the present pandemic so well. We have one character like Malik also in that movie. So we have to promote the fact and we have to disperse the fallacy. In this sense, we should be more active. And the third one is, I will talk about that. I will post the third one in the messages because I don't want to take more time. Thank you.
Thank you very much, sir. I will answer the first question. Because the problem with that approach is, one, we have only one precedent which says that 3 waves were there. 2, we are not sure if the Spanish flu pandemic will be similar to COVID pandemic or not. We are definitely not sure. 3, we have no evidence, not an iota of evidence to say that Omicron is less virulent rather than Delta. Now, infection rates are climbing up in South Africa because the test positivity last week was only 5% and now it is around 15-16%. So it is hugely spreading. That far we know. But hospitalizations will start mounting 2 to 3 weeks after the numbers mount. And then death toll will start after 2 to 3 weeks after the hospitalizations mount. So we are not certain that Omicron is less severe. That's why let it rip is a very, very, very dangerous concept. We cannot go there. We have to mitigate this. This is important. We have to stay away from that. We have to advise people to wear a mask. We have to advise people to take that vaccination. And then letting it rip in the present situation, losing so many lives is not at all an option. That's what I made clear in one of the slides, and I'd like to reiterate again. And the second thing is, like you said, fact check is very important. We concur. So I'm not answering that. Thank you. Thank you very much, sir.
Yeah, Dr. Mukherjee, before going to the others, I would wish that you should answer some of the questions on the chat box as well. And the question is that Professor Sudha asked as to why Western countries have high numbers of COVID instead of even if they had good vaccination, even though they had the booster. Why the numbers are higher in the Western world?
No, this is very important question. We need to learn from that question in the sense that vaccines are not actually preventing a Delta infection completely. What they are preventing is the number of hospitalizations and number of deaths. Now, there is a commentary that was published in Lancet yesterday, which said that we can no longer ignore the epidemiological significance of people who are vaccinated in spread of the COVID-19. That is a commentary, beautiful commentary, you should all read it. Now, why this thing is important is vaccinated people are getting infected. Vaccinated people are also spreading the infection across to other people. But the thing is, they have around 90% protection from hospitalization or death, and that has been consistent across the nation, and that is a very, very important point to understand. Vaccination. Now, if you take the first wave and there's the second wave and the third wave, Europe had already 3 waves. The third wave, which has come after the vaccination, there is a big dichotomy between the numbers of infected and the numbers of the people who have died. So that means that this dichotomy or this divergence of the waves has come because of the vaccine. So definitely vaccine is helpful in preventing hospitalization, serious infection or mortality, but perhaps it is not so effective against the infection, because the Pfizer vaccine, the efficacy rates as far as the symptomatic infection has fallen dramatically after 4 to 6 months in Israel. We have seen that. Some studies have put it around 30% for the infection. But for the hospitalization, for the death, it is still around 90%. So that's where we should have informed people that the vaccinations are predominantly working against the hospitalization and death, not so much for the infection, symptomatic infection.
Yeah, in the same go, it's related rather. Srinivas Jagat asked, what if somebody has a positivity after 2 doses of vaccine? Should he go for a booster dose? Is a question.
Which positivity, sir? Positivity means?
COVID positive after 2 doses of vaccination. What would be the
right
protocol
now,
for, yeah.
Right now, the highest protection is being is being seen in those people who have a hybrid protection. Hybrid protection is people who have been infected and followed by vaccination. These people have highest level of protection against subsequent infections. But if a person has 2 doses of vaccine and then later gets infected, perhaps he may not need a booster. But as far as the United States is concerned, this is not a criteria through which they see a booster dose. They see all the vulnerable population should receive a booster dose. That's what even CDC and FDA guidelines have been slightly different. And now they are most aligning, because with the onset of Omicron, both are almost aligning. Now, people who are at risk should take a booster. That's what is the stand in the US. But in India, still we don't have any approval for any booster dose. So the question of taking a booster dose after 2 doses of vaccine and infection doesn't arise in India. But that's where my call becomes important. My call is to find a correlate of protection very fast. That is very important. If we don't find a correlate of protection, we'll keep on vaccinating people who do not need it. And then we cannot pass on the benefit of vaccination to those people who definitely need it.
Yeah, thank you. Dr. Buddharaju, can you go ahead and ask the question and share your expertise?
Thank you, Andy. Thank you, Dr. Mukherjee. That was pretty insightful. Like he said, there's been plus and minuses during this pandemic. We've learned a little bit. There's, I think, a lot more to learn. As far as the US hospitalizations are concerned, what we are seeing is more than 95% of patients who are currently hospitalized, and that number is actually going up, is unvaccinated people. In spite of having plenty of vaccines, we're dealing with all kinds of conspiracy theories and alternative motivations not to get the vaccine. And that might be partly policy failure, that might be partly educating the public failure. And so every country is facing that at some level or the other, either in terms of getting people vaccinated or following COVID appropriate behavior or things like that. One thing the pandemic has taught us is spending a lot of money on healthcare really hasn't had much of benefit. The classic example is Europe. Most of Europe has some of the best national health systems. And we can see what's going on right now. India spends about 1% of their GDP or less, maybe, on healthcare. I'm not sure India has done any worse than, if not better, than any of the European countries, which spend about 20% of their GDP on healthcare. With small countries, populations the size of Andhra Pradesh. So we're seeing 50, 60, 70,000 infections a day in Germany, which has one of the best national health systems and also technology. That was one comment I wanted to make. Number two is testing wastage or sewer systems. I don't know how much it's going to work in India, and Germany has used it, US uses it. because we have structured drainage systems and sewerage systems that can be easily accessed and the target population identified. Except for maybe the major metros in India, maybe Hyderabad, maybe Mumbai, I'm not even sure about those, if those drainage systems are actually structured enough that we can identify based on a positive RT-PCR from wastage, target population or target community. Certainly it's a big problem in smaller towns like Vizag or Vijayawada. They don't have sewer systems to kind of accurately assess that. So bottom line is basically, each country, each community has to come up with its own solutions. The most important thing of all we've learned is basically not rely on just hypothesis alone. And, it's okay to have hypothesis, but I think the hypothesis have to be tested, peer reviewed, and the level of evidence has to suggest that hypothesis is correct. The problem has been, and it's just not in India, I mean, it's all over the world, is people hypothesize and an assumption is being made that that hypothesis is correct. And unfortunately, 99% of the time, those hypotheses have been wrong. And so I would be wary in making assumptions that Omicron may be less virulent or will do something different than Delta. At least for now, there's not enough data to suggest that its behavior is any different from Delta in terms of number of hospitalizations or virulence, but that data is yet to come out. Hopefully in the next week or two. I think the WHO is doing a far better job now than what it did about a year ago in terms of analyzing data. So I think in a couple of weeks, we should have enough data that's solid enough that we can kind of predict or guess how the variant is going to behave. Until then, I wouldn't make any assumptions. I would actually double up on getting ready for a potential large surge. And from our experience with previous variants like Delta, we know that within a period of 3 to 6 months, basically the entire globe is going to get affected, number one. Number two is there's been a lot of commentary on travel restrictions. By now, I think everybody should know that there's enough data to suggest that travel bans or travel restrictions haven't really done anything. And, the classic examples are Australia and New Zealand. What they do is they probably delay the onset of the surge to prevent, overwhelming the healthcare system. It gives you some time. That's the best it can probably do. So one thing the pandemic has done is not just the infections and the healthcare costs. There's been a huge social cost. There's been a huge economic cost to all the societies in the world. And that has to be kept in mind, because at the back end, after we deal with all these restrictions and economic slowdowns, we're going to deal with some other problem in the societies. And those are the comments that I wanted to make. And I was hoping Dr. Mukherjee would add some comments to that.
Yeah, thank you, sir. Very, very insightful. I would like to comment like this. One, India spends only 1% of its GDP on healthcare, and the mortality has been less in India despite this, not because of that. I'd like to say that Europe spends 20% of its GDP, and still the mortality rates are high. And India mortality rates have been okay, despite that we spend less on that, not because we spend less on that. That is one thing that I wanted to make. And the second thing is 90% of the hospitalizations in the US are unvaccinated. And I'd be happy to share that the early data that is coming up from South Africa also suggests the similar statistic, even in Omicron variant also. 90% of the people who are admitted are unvaccinated, though the Omicron variant has a lot of immune escape properties. It definitely has some bad mutations, especially P681H and P681R. These are the conferring immune escape mechanism for both the vaccine-acquired immunity as well as the naturally acquired immunity also. So because there is some immune escape, the possibility of vaccines not being effective has been arising. But the hospitalizations have been predominantly in people who are unvaccinated. And that is one of the things, even in Omicron variant. That's what I wanted to say. And you made so many observations that I almost forgot most of them.
Yeah, I mean, yeah, we largely agree upon whatever he has said about the economics of throughout the world. Yeah, Dr. Shantipriya, you are there? You wanted to ask a question? If she's not there, Ramohan, you have a point to make. You had your hand up. Yeah.
Dr. Mukherjee, I need a little help here. The Pfizer and Moderna vaccines are somewhere between 90 to 92% effective. That means somewhere around 10% of people are not protected. So why is it such a big surprise that so-called vaccinated or injected people are getting COVID infection? Because it's only 90% effective. And if you look at the total number of people who got infected after receiving those two vaccines, the number is far less than the 10% that were vaccinated. So I was curious why we keep using the term vaccine escape. First of all, the vaccine is not 100% effective. I may be completely wrong on this topic, but wouldn't you educate people? Look, the vaccine is not 100% effective. So if you're unlucky, even after the vaccine, you have a 10% chance of getting the infection. I was wondering why this doesn't come up, unless I'm missing what's coming up in the public health news. Do you have a comment, sir?
Yeah, Dr. Ram, you're not missing anything. That was 90% or 92% efficacy. In fact, Pfizer is 95.5% efficacy. That is even you have Sputnik, which is 91.6% efficacy. These are efficacy rates against symptomatic infections in a clinical study protocol. The real world efficacy has been slightly different. See, in real world, what we are trying to see is both symptomatic and asymptomatic infections, for which the protection is much lesser. This is only against symptomatic infections, it is above 90%. Against, when we compare it with both symptomatic and asymptomatic infections put together, the efficacy falls. And then once the delta emerged, the efficacy has fallen further. And after 4 to 6 weeks after the second dose, the efficacy has fallen even further. So in real life, we have seen a lot of people who are vaccinated getting infected. But one consistent observation is, like Dr. Budhraj mentioned, very few people who have been vaccinated are getting admitted into the hospitals. So 90% of the people who are admitted in the hospitals are unvaccinated. So initially, what was studied in the clinical trial protocol for the Pfizer or Moderna, whatever vaccine is, symptomatic infections have been studied. And those were put above 90%. So there is a difference in terminology. That's why this problem has been coming up.
Yeah. Ramohan, with regards to the public education, we have always been telling that vaccine is useful to the extent that you will not have severe infection. And with that's how we are telling people to go for vaccination. Vaccination is very, very important. And we are asking people to go vaccinated. The moment we say that you might get an infection even after vaccination, there is every chance that the people may not go for vaccination. But in the same stretch, we are telling people to go for vaccination, and you are, even if you get an infection, you are likely to get a lesser infection, the lesser chances of hospitalization. So this is being driven into the minds of the people very well, I think, through various fora. And Dr. Venkateswara is there, the pediatrician. Dr. Venkateswara, you can go ahead and ask your question.
Yes, sir. Actually, the hospital has done one study in especially pediatric age group. Nearly 250 children less than 18 years who have studied the IgG antibodies, SARS IgG antibodies. Surprisingly, children more than between 12 to 18 years, almost 90% of children have very good antibody titers. And between 6 to 12 years, almost 70% to 80% of the children, they have very good antibodies. Surprisingly, children less than 5 years of the children, less than 50% of the children have antibodies. We have seen even 2 days newborn baby, 20 days babies having the high titers of the antibodies. Even the mother doesn't know, the mother didn't know that she had COVID during her pregnancy also. So at the end of the story, most of the children in our Indian population, both from the rural, urban and semi-urban areas, and especially children more than 12 to 18 years, they have very good plenty of antibodies. Second thing is, till now, Omicron, we have seen patients from the immigrant patients only, immigrant population only. Because before they start people traveling from one country to another country, definitely they're supposed to take 2 doses, and they should be asymptomatic before starting the international travel. So the people who are coming to the other countries, even RT-PCR also they have to undergo, and the RT-PCR negative people only they are supposed. So that is why we have to wait till 2 to 3 weeks for the real dynamics of the Omicron variant. The other thing is, the vaccinated people, even though people have taken 2 doses of the vaccination, the amount of the virus load carrying by the vaccinated people versus unvaccinated people are the same. Though he may not affected with the disease severity, but he is likely to spread to the unvaccinated people. So India, like now, we are afraid of the third wave of the Omicron. Let us trace one unvaccinated patient, unvaccinated people. For example, any patient coming to the hospital, you have to clearly ask whether you have taken 2 doses or not. If they have not taken, we have to take the list of the people. Like that, any malls, any hospitals, any offices, whatnot, everywhere, reach each unvaccinated people and let them vaccinate properly. That is so that the vaccination drive will be still more. I had a good discussion with the superintendent of police in Vijayanagaram. She told me clearly, almost all frontline officers of the police officers have taken vaccination. Unfortunately, 60 to 70% of their families, police people family, they have not taken any vaccination. So still people are there, unvaccinated people are there and everywhere. So we have to identify them and to catch them and get them vaccinated, so that only we can prevent the vaccination. I think Mukherjee can give some more insights into this talk.
No, first of all, I congratulate you, Dr. Venkateshwar, for having done a study which has told you that around 90% of the kids are have antibodies. That's what I have covered in my talk. See, the important thing is the antibody tests may have false positivities and false negativities. They are not properly standardized. They can be nucleocapsid antibodies, they can be spike protein antibodies, they can be neutralizing antibodies, or any combination of these. So the antibodies do not infer or confer protection to those people who have it. That is what is important to understand. Because when you say that 90% of my kids are having antibodies, people think that 90% of your kids are protected. That is not an actual correlate of protection. That's where, if we don't tell that differently, people will say that, okay, now only 10% of the kids are left without antibodies, without protection. Let Omicron rip through the scrolls. That way, we can infect all the 10% also, so that we can easily achieve herd immunity in the next 15 to 20 days. That's what people will think. That's why it is important to bring out the difference between those people who have IgG antibodies versus those people who have protection. We don't know where this Venn diagram actually lands. So that is one important observation. Second thing, what you said is important. Even vaccinated people have the same amount of viral load and they may transmit. But still, they'll be protected against hospitalization or death. That's why it is important, like you said, to identify people who are not vaccinated and get them vaccinated. And it is the individual responsibility. I am trying to convince my own driver to take a vaccination. He is so bent against it. He is sitting in my own car, and I could convince him when the travel restrictions have come up. So this is what is in people's mind. Some people are so hesitant and so afraid to take vaccinations. We have to convince them and then improve the vaccination rates further.
Yeah, thank
Even
you.
the
Professor
antibody test is
Sudha.
also, sorry, sir. Even antibody test is also not rapid antibody test, sir, we have done. We have purchased one biomedics company machine that was also installed in the very famous laboratories, where we can identify not only spike antibodies and other antibodies also. But at the end of the story, sir, can we suggest any people who have very good antibodies following primary infection or by following 2 doses vaccination? Because most of the phone calls what I got from the public now, sir, can we take third dose? Can we take third dose? Like that, they are keep on asking that question. So if they have good antibody titers in the body, so can we suggest them to not to take booster till another 6 months, like that?
The problem is we don't know how good is good. Let us say 500 arbitrary units. Let us think 1,000 arbitrary units. How much of antibodies is protective enough? That's what in the beginning only I said that this is the most important thing that we should be researching on. We're not able to do that. That is number one. Second thing, I would request you to follow up all these 250 people, kids, and then see if any of them are getting infected later. If none of them are getting infected later, that is a very good thing, because these people have a bit of protection. That's what we can see. So let us follow them up and then see for our own answers.
Even the second wave admissions also, only to go, my hospital is a children's hospital. Government has taken for time being 99% of the population are only adult population who are not vaccinated. Out of 200 cases I have treated, only two patients are partially vaccinated, and only two children were admitted because of the force only, because they belongs to high income group. So because of the afraid only they have taken, because symptoms are very, very less in childhood, sir, children also, even peak pandemic also. So at the end, maybe our Indian children may be protected in future for Omicron also. Hope for the best.
That is a dangerous assumption to make, and then I would not make that.
Hope for the best.
Yeah.
Right. Thank you.
Yeah. And Professor Sudha, please go ahead. You raised your hand, Professor Sudha.
Sir, your phone is on mute.
Yeah. Good morning, Dr. Mukherjee. I am Dr. Sudhakar, Professor of Medicine from Guntur Medical College. Actually, I have been working in expert committee in command control room. I have been watching all your videos in the TVs also. A very nice presentation. Just I want a small suggestion here. You said some of the patients, those who are immunocompromised. So in those people, the virus is long lasting. So it is there for months together. Because of long lasting, so their mutations have been occurring, and then they are responsible for this what you call Delta or Omicron. It's okay. But thing here is whether this during this particular period, this months period, but whether that particular person is infectious to the other people or not. If it is so, definitely we have to again put the RT-PCR negativity test to all the people who are affected by the COVID, because now the government of India removed the COVID PCR, RT-PCR testing after 14 days. Just only if the RT-PCR is positive, after 14 days, just simply we have to discharge the patient. But if it is so, if there is an infectivity of those particular patients, definitely we have to repeat regularly. And once the patient is RT-PCR negative, then only we have to advise the patient to go into the society. I think this is a good thing the government has to do.
Because of logistics, most governments have taken out the negative RT-PCR test as mandatory for coming out from isolation. Most governments, not only Indian government, even US government doesn't have any such requirement. That's why I was requesting all the governments in the world to have at least people who are immunocompromised should have this RT-PCR negativity. They are infectious. There is no doubt about it. Otherwise, if they are not infectious, even if the new variant comes, how did it come into the public? Now, let us say Delta variant has come in such an immunocompromised person, but it has reached the public. because they were infective only. The maximum was 108 days or something, that infectivity. But most people will not have months together. But they may have some 2 weeks or 3 weeks more than ordinary people. So identify people who are immunocompromised and then make it advisable for them to have an RT-PCR at the end of isolation. That is my suggestion, sir.
Yeah. Thank you.
Yeah. Yeah, Dr. Murthy is there. Murthy wants to say something.
Yeah. Good morning.
Yeah, please go ahead, sir.
I could catch up with in between the talk only, but whatever little I could grasp from the presentation, it was a nice presentation. I would like to make 2 or 3 observations. And first of all, on a lighter side, Dr. Buddhi Raju's burning question was really burning because I saw some fumes coming on from video. And the other thing is, we have treated a significant amount of population during 1 and 2 in my institute. Now I am facing the problem that whatever COVID positives we are admitting, at least I can definitely say and vouch upon that 90% of them are not vaccinated. This is a small reflection of probably the thing which is prevalent across at all places. So this means that as a public administration, we have failed somewhere to ensure that the population is not fully vaccinated. And at times I also get a doubt and to take the statistics which are being shown with a pinch of salt. The third thing is the unwanted fear and the irrational application of having the third booster on various fancies, whether you should take the same or the mixed variety or a cocktail. All these are giving rise to probably certain things for which we are not aware of, and we are still lurking in a place where the knowledge is very gray and people are being taken for granted. And the last point I would like to mention is the public administration should come heavily on the implementation of some sort of an immunity passport to ensure that everybody gets vaccinated, failing which they'll be deprived of certain privileges for which one is entitled in the society. That's what I thought. Otherwise, it becomes only a scientific discussion, and the end result is we'll keep facing these problems day in and day out. That's it.
Yeah. Mukherjee, do you want to say something on that?
No, sir. He was making the same point, sir. That was good. That was good. Thank you, Dr. Mukherjee.
Yeah.
Thanks, Andy.
Yeah. There are others like Lakshmi's iPhone rose the hand. There's a hand raised from Lakshmi. Yeah, Lakshmi.
Thank you, Sudhakar Garu. Thank you, Dr. Mukherjee, for such a very good, excellent presentation. Thank you all the doctors for very good comments. I am Dr. Lakshmi Lavanya. I'm an endocrinologist, American board certified, returned to Hyderabad, practicing here for 10 years. I have been just like Dr. Mukherjee, not as much as him, but maybe 30% of him. I have also shown great interest in this COVID, other than it has been my co-curricular activity other than my regular endocrinology practice. So I have been a public educator, blogger, and researcher, and maybe a reader, writer in this topic. So I have been also a think tank in this process, and I've walked along with other experts in this field in relaying the news to the public mostly, and also participated in these CMEs. So with that, I think with that background, Dr. Mukherjee has really taken it really, really well with his 15 lessons, very simply put forward. So one thing I would want to just ask a question, because I don't have a complete clarity on this, and I'm trying to research also. Talking about booster dose at this point of timeline of COVID-19 pandemic is a sensitive question, keeping in mind vaccine equity across the globe and also vaccine equity across the country. So unless we get our second dose without hesitancy, with ease and with success, about 90% of the Indian population, being vaccinated double dose, we can't really bring up the topic of booster in such a confident manner. But since the eruption of the third wave or the new variants, we have to talk about it and we have to formulate a policy on this. So the policy is being held because the expert committee is still discussing on it. What do you see, Dr. Mukherjee, with the two mainly vaccinated in our country, Covaxin and Covishield, other than the data from the US that the third dose could be easily given due to high efficacy of the third booster by the mRNA vaccines, which is the Pfizer and Moderna, followed by the other three, JJ and the other three which are next in the line, AstraZeneca and Johnson & Johnson and Sputnik were the next in line. The other three were all mediocre, they are saying, for third line booster. Now, in India, we know that Covaxin has a different mechanism of action than Covishield, but we also know that there was a test done by ICMR in Uttar Pradesh where 28 individuals who inadvertently took the wrong vaccine of the second dose, and the antibodies were much higher in the mix and match group. That means those who took the Covishield first and Covaxin second dose as a mistake, inadvertently taken the second dose. We all have talked about this study in the past. So those people had better antibodies. Now, do you suggest a booster dose with a mix and match concept, or do you suggest a booster dose with the same vaccine that the people took in the first and second shots, the same dose or a higher dose? And how much is the timeline gap that you would recommend after the second dose, or something like that the government should be taken as a policy? Of course, it will be nice if government takes all of our suggestions, but I don't know on what basis government makes its own association and just releases the policy without taking an expertise from many of us here. But what do you say, Dr. Mukherjee, in this line?
Yeah, when you are saying 30% of what I do, you are being too modest. You are doing great work. First of all, let me congratulate you on that. And regarding boosters, I think it is time for us to talk about the boosters because we have enough vaccine supply, one. And two, because people who have got the first two dose vaccines, they are having waning immunity. That is for sure. Now, what is sure is boosters are necessary. What is sure is boosters show benefit. But what is not sure is the adequacy of the vaccine doses. So if the government has adequate vaccine doses, then we can think of the booster doses, because Omicron is specifically attacking the front-end population first. Now you see, in Israel, there are 2 doctors affected among 4 people. In India, among 4 people affected so far, one is a doctor who was double vaccinated again. So people in the frontline warriors are the healthcare workers. They should definitely receive booster doses if the vaccine doses are adequate. If it is moral enough for us to take, there is definitely a need and a benefit with the booster doses. There is no doubt about it. Whether to take a mix and match or the same vaccine, there is a Lancet study published last week, which has evaluated 7 different vaccines, following either a Pfizer dose or AstraZeneca, Pfizer or AstraZeneca. These are the 2 initial doses that were given because this trial was from UK. And then they studied 7 different vaccines, and any combination has given a very good antibody level, particularly those with mRNA vaccines following an initial viral vector vaccine has been given a very good antibody generation. But only one vaccine among the 7 did not give a proper boosting response. That vaccine was Valneva vaccine. It is from France. Unfortunately, it is a type of vaccine that is whole virion inactivated vaccine, which is amalgamated with a booster. So that only Valneva did not show much benefit. Rest all 6 vaccine doses, even CureVac, which is now, it is not continued now. The CureVac is discontinued, the mRNA vaccine. And all the other vaccines as booster doses have done particularly well. But I have my eyes especially on a protein subunit vaccine. Protein subunit vaccine is cheap. It is protein subunit vaccines have very less complications, and expensive protein subunit vaccines can be mass produced and given as boosters so that the supply chain will not be affected. As boosters, perhaps protein subunit vaccines are the best. But if you have to choose among these vaccines, and now what I'm going to speak will be my own opinion rather than backed up by evidence base. if you have only Covishield and Covaxin. For people who have taken initial 2 doses of Covishield, Covaxin would be better because of the small study that you have mentioned in Uttar Pradesh, where they have inadvertently taken the vaccine doses. So even when a first dose of viral vector vaccine followed by Covaxin has given much better antibodies rather than 2 doses of viral vector vaccines or 2 doses of Covaxin. So it is better to mix and match there. That is number one. We don't exactly know what to do with people who have taken 2 doses of Covaxin to start with. Perhaps we should divide them into 2. People more than 50 years of age, perhaps they should take Covishield, and people less than 50 years of age, because of a rare chance of having a clotting disorder, they can go with Covaxin again. But this is again purely my own recommendation, not with any governmental backup, not with any sort of extensive evidence in this regard. That is my assumption. And the second thing is when to give the booster doses. Perhaps 6 months after the last dose would be the best time to give the booster doses. But again, what I'm requesting the scientific community is to come up with a proper correlate of protection so that we can decide when actually to give a booster and if actually we have to give a booster. That would be a great godsend thing if that comes up.
Yeah. Thank you, Mukherjee. May I ask the iPhone user to pose his question? iPhone. If he's not there, Dr. Buddharaju, do you want to say something?
Yeah, about the boosters, the decision from CDC and NIH in US was, somewhat based on data, initially approving boosters for healthcare workers, at-risk people, and people over the age of 65. And then more recently, they approved it for everybody, all adults, basically. That was based on, evidence from, Israel and Pfizer, where initially the surrogate used was neutralizing antibodies, and specifically, neutralizing antibodies. And those data with neutralizing antibodies actually correlated with waning immunity and reinfections or infections in vaccinated people. So that was the data that CDC, I think, used to recommend boosters. So India should, has a robust vaccination program now and data monitoring programs, I'm pretty sure. So it should be easy for them to actually, take a sample of 20,000 or 30,000 or 50,000 of people who got both the doses of Covaxin and Covishield, and 1, check for their neutralizing antibodies, and 2, actually prospectively monitor them for infections, breakthrough infections. So I might be ignorant, but I don't know if Dr. Mukherjee has any data about breakthrough infections with for people who got Covaxin and Covishield, both the doses, and if so, at what point are they happening? Are they happening 3 months after the second dose? Are they happening 4 months after the second dose? I think that's the kind of data that ICMR would want to know before suggesting booster. Obviously, vaccine availability is an issue. There's a significant population that hasn't gotten the second dose. So I have a feeling that the government is not interested in booster recommendations right now because they want that 100 crore people to get both the doses of vaccine before they think of boosters. And also, India has been very generous in terms of shelling out vaccines to African countries, and that can be said about US in terms of distributing vaccine. So they're doing larger good for people outside India. But I think that I would base that booster dose decision based on data that's been collected. I'm pretty sure. I don't know if Dr. Mukherjee is aware of any of such data.
There are a lot of studies for the breakthrough infections, sir, but most of them came just after finishing the 2 doses. When the Delta was ripping through India, that time a lot of studies have come. The study has come from AIMS, the study has come from Vellore, study has come from PGH Chandigarh, study has come from Fortis. All these have put together the breakthrough infections at different levels. Some people said it is around 2%. Some people said it is around 16%. But this is not exactly after a particular period. They did not compare breakthrough infections after 14 days with after 6 months. That is not what was compared, because after that the cases plummeted. Once after the June 15th, in India, the cases have been pretty low. So no breakthrough studies have come up of late. All the breakthrough studies have come up during the pandemic, during the second wave of pandemic. That's why the exact information that you asked for, initially after 14 days after vaccine, versus the one that is after 6 months or 4 months after the vaccination. This comparative data is lacking still.
Yeah. Before I wind up, last question by Dr. Vijay Shekhar. I'm not taking too many questions from the chat box because they all have been already answered during the discussion. And Dr. Vijay Shekhar, make a quick comment, and after that, I'll wind up. Vijay Shekhar, are you there?
Sir, yes, sir. Yes, sir.
Yeah.
Sir, it is a very good point brought by Dr. Lankeswar of Vijayanagaram, and also Dr. Sudhakar from Guntur also has raised a really good point. Sir, there are several administrators and officials experts in this group. Just like as it is made mandatory to enter an airport, one person should have a fully vaccinated certificate. Can we recommend to the government or local authorities in the peak time of COVID, they used to give sanction letters for conducting marriages also with less than 50% or so. Similarly, if we can recommend to the government to keep vaccination counters at the public places, those who are not fully vaccinated, probably it may benefit the society. I request all the experts to think over it.
Yeah. In the same stretch, I wish to tell those people who are on the board as advisors to the government to make government aware that it is not the vaccine hesitancy or non-availability which is a problem, it is the vaccine complacency. Most of the people are complacent, they are not taking the vaccine because there are not too many cases nowadays. So we'll have to concentrate on those people who have not taken the second dose. We should devise a mechanism so that each one of them will take the second dose as well. And at the same time, they should recommend to the government that the frontline health workers should always be given the booster dose simultaneously as the second dose goes on. So these are the two recommendations that perhaps they should make to the government. And so with that note, I wish to thank Dr. Mukherjee very profusely, because you must have seen the crowds have crossed more than 200, and there were more than 200 participants on board. And there are a lot more questions that are coming up in the chat box as well. As we have this time constraint, I wish to thank him again. I wish to thank all those who have participated in this discussion, a lively discussion. And what a fitting finale we are going to have next week. Next week, we are going to have not at the same time, but at 6 p.m. We will have that in the evening. We'll have a dual mode, like we'll have a hybrid mode, physical as well as the online. And we will have most of the medical students have shown their interest to join that. So we will have an LED projector there, which we will be transmitting the entire show. And Dr. Sridhar Chilumuri will be addressing the final and the 100th episode of our weekly webinars. With that note, I thank each one of you for participating, Dr. Kairam and Dr. Buddharaju for your comments as well as suggestions. Thank you one and all. With that, we conclude this meeting.